In 2019, we introduced BGaze in the diagnostic protocol, and, as I said, we administer it to all patients who were admitted to the center, as well as our outpatients. Of course, at the same time, we carry out a structured interview of ADHD. Also, the school and medical histories are evaluated, as well as the functioning in school.
Y se evalúa la historia clínica, escolar, se hace observación en aula y los espacios de la escuela.
Here, I explain the case of a patient, a 16-year-old patient, family problems and social and academic dysfunctions, without a previous diagnosis nor a prior mental health follow-up, and with a preserved school performance until the first year of high school. Something which is frequently seen in our patients. The patient is disorganized, inattentive, restless from childhood, but studying first year of high school. We administered the test, and I will show you a screenshot of the report. One of the characteristics of the tool is that it automatically generates a report. It makes a calculation with all the variables that enter the system, and then it gives you immediately the final report. It displays and tells you according to its parameters whether the probability of having ADHD is high or low. In the report, there is a figure with a bar of low, medium, and high probability, which is colored in red as it progresses towards what is quite probable having ADHD. And it clearly indicates to us that if the marker is in the lower part, it is unlikely that the patient has ADHD. If it is in the middle range, you have to look for other clinical parameters that support the diagnosis. In the upper range, it is unlikely that the patient does not have ADHD. The following calculation that it makes is severity. The report tells you that the symptoms are, in this case, severe. Note that this is a patient who never had been diagnosed before, and here presents severe ADHD. The report also explains the profile that the system calculates, but they are very cautious in their definitions, because there is a lot of scientific supporting knowledge the BGaze tool. We know that the profile of a patient can sometimes go through different profiles. There may be an indication of a combined profile, but what clinically is observed as a problem only in attention or only in hyperactivity.
Una apreciación de perfil combinado, pero que clínicamente lo que esté dando problemas solo sea una inatención o solo una.
This is a CAPTAIN, a continuous performance test, that is included within the BGaze assessment. I like to present it for this patient, because when we do a cognitive test, without measuring what the real cognitive path of the patient the result, and what we see is only the final result. What you see is that many patients in short tests are motivated to perform the test well, because there are many things that are caused by fatigue. Thus, a 10 or 20 minutes test is not the same as a 6 hours assessment in the center or classroom. So the interesting thing about this test, in this specific case, is the rate of the different errors. Say you click on the fish, when you should refrain from clicking it, or when you failed to click on the tadpole. You see that the patient doesn't make many mistakes. The error rate is within the general population. What you see differently with this tool is that the patient had to make a greater mental effort to reach that result than that is made by the general population, because they have to control fixation. They have a much wider area of visual fixation, which is what is seen here in the hyperactivity analysis, when you do the impulsivity analysis of the eye movements. You also see that there is an increase in the saccadic pattern, and that there is also a discrepancy between what the left and the right eye does, because the patient has a poor lateralization of this eye pattern. You also have the typical attention analysis. So, there is a lot of data, but it is very, very easy to understand the results. So what has happened since we have introduced the BGaze test in 2019? Well, I did a search of all the ADHD diagnostics that we have done. on patients admitted since 2016 in CanROS. What we see is that in 2016, there was a prevalence of 17%, in 2017 we reached 22%, and in 2018 there was a prevalence of 25%. In 2019, we incorporated the tool. And see what happens. We went from a 25% prevalence to a diagnosis of 44%, so, we doubled the diagnostic capacity. And this is maintained over the next 2 years. Well, what does it mean? It has certainly had an impact on the diagnosis. We have had more ADHD in CanROS. This is an irrefutable fact. If this is good news or bad news, we will have to contextualize it, in respect to what the literature says. The literature says that in the adult outpatient population, there are 20% of adults with ADHD. And in adolescents it is estimated to be between 25 and 65%. Because I believe that now with a 44%, we are much more adjusted to what is the real prevalence of ADHD. Therefore, for us, the tool is important. Not just for doing the screening. Because using the tool is definite answer. Would be a misuse of this tool. But yes, it is true that it forces us to make the effort to see if what we observe clinically agrees with the test, and if not, then to see what the discrepancy is and resolve it. In this way, we are much more on top of the ADHD diagnosis. Thank you.